Restart the recording. Thank you. Welcome back, everyone. This is a hearing regarding Connecticut Children's Medical Center's application regarding the relocation of inpatient pediatric services from St. Mary's Hospital in Waterbury to CCMC's main campus in Hartford. It's docket number 26-32825-CON. It is about 10:42 right now. We're going to continue with DPH questions regarding the application. So I'm going to turn my focus now to sort of the general concepts of access and specifically Medicaid access to these services. Actually, before I do that, Attorney Jensen, did you have an opportunity to look at that question that we had regarding public notice in January 2025?
Thank you, Hearing for Chuka. We're still looking into that exactly. I want to make sure we give you accurate information, so we're still looking to confirm that.
Okay.
I believe there was one clarification that Mr. Duncan wanted to make about some prior testimony. If now would be a good time for him to address that before you get into your next line of questioning.
Sure, that'd be fine.
Mr. Duncan, I think there was a question relating to the moving of beds that were previously allocated to the St. Mary's unit. Did you want to touch on that, please?
Yes, sir, I would. So Hearing Officer Chuka, you asked me the question. We quit providing services in January of 2025. However, the beds remain there, very similar to the other question about that space. We continue to keep those beds there until we get the approval of this application. So I wanted to clarify the beds have not been moved. Only the staff and the services of the patients have been relocated here.
Okay, thank you. So as I mentioned a moment ago, I'm going to turn my focus to access now. On page 168 of CCMC's response to the completeness letter, it uses the term unfavorable payer mix. Specifically, it says, the St. Mary's unit has historically operated with a negative margin year over year due to a mixture of low census, high expenses, including to staff and maintain licensure compliance for a unit off the main hospital campus, and unfavorable payer mix. So my question is, can you describe what is meant by unfavorable payer mix?
I'd be glad to. So as a children's hospital, first and foremost, we accept all children regardless of their ability to pay. When we mention unfavorable payer mix, Connecticut Children's is approximately 55% Medicaid across the system. And in this state, Medicaid, we've not seen a rate increase in almost 10 years. And in this state, for every dollar we spend, we only received 53 cents on that dollar. So I often tell people, how many people would open up a business? So as it relates to Waterbury, because you have such a small demographic market, and with the inpatient census only being an average of less than 3 a day, in most situations, you have a strong mix of commercial to help offset the 47 cents you're losing on every dollar spent for the Medicaid. But because the census is so low, there's not that opportunity to spread that cost, which made the losses there that much more significant. Is that helpful?
It is, yeah. So you touched on this a little bit a moment ago. In the filings, so you said 55% is what CCMC, the Medicaid population, is servicing across its entire system.
It fluctuates between 55 and 60% across the system.
So the St. Mary's unit's utilization was 82% Medicaid. Does that sound correct to you?
That is correct.
do you have an explanation for the difference between the two? And I understand you probably just touched on this in your prior response, but if you can provide some more detail, that would be helpful.
Sure, it's a matter of demographics and a small N. So when you have a small population, you tend not to be able to spread that across. So when we look at the utilization across the system, we receive kids from all across the state, and that helps balance some of that. When you look at one specific area, that Medicaid mix looks very different. We could do the same thing for Hartford, do the same thing for Cheshire, and that Medicaid mix would fluctuate depending on the demographics of that community.
My understanding is that Hartford generally has a higher Medicaid population than Waterbury.
If you look at Hartford directly, yes.
Yeah, the greater Hartford area has a higher Medicaid population than the greater Waterbury area. Controlling for the same services that were provided at the St. Mary's unit, are you aware of whether the payer mix is roughly the same in Hartford as it was in Waterbury?
Not sure I understand your question.
So if you were to look at the same services that were provided at the St. Mary's facility as they are being provided in the Hartford facility today, if you were to isolate those services and payer mix for those services, would they be the same as they were in Waterbury now in Hartford?
If you look at Hartford specific, that Medicaid mix would be the same or a little higher. If you look at the Hartford campus and the market we serve, that Medicaid mix goes lower because we're drawing kids in from all across the state and across different economic and demographic areas.
Okay. Thank you. A moment ago, you indicated that Connecticut Children's gets reimbursed at a lower rate than most other hospitals in the state for Medicaid patients.
That's correct.
So in one of the filings, I believe it was Exhibit M, the issue responses prior to this hearing, Connecticut Children's referenced a Fitch Ratings website, and on that Fitch Ratings website, it mentioned the state's directed payment program. Has CCMC engaged with either the Centers for Medicare and Medicaid Services or the Connecticut Department of Social Services to adjust its Medicaid rates to be similar to other hospitals in the state?
Yes, we've been in conversations with the state concerning the Medicaid rates. And just in this past session, we were actually included in the provider tax that we've not been involved in the last 10 years. And so we were excited about that opportunity. However, the changing environment out of the federal landscape, we await the final approval of whether we will be able to benefit from that opportunity or whether we will not be able to benefit. And at that time, we'll be continuing to work with the state to see what we can do to adjust to take care of the children of Connecticut.
Okay. I didn't realize that about this past session, so that's good news.
Like I said, the state's been wonderful. We'll just wait and see what the feds do.
Okay. Switching, still within access, but looking more sort of at patient affordability more generally. So from what I can tell, all patients who are either not eligible for transfer to Hartford via ambulance or are not eligible for transportation assistance due to certain income thresholds, they will need to sort of, self-fund their own travel to Hartford. Is that correct?
That's correct. However, we have a policy. We work with all families throughout the state because, as you can imagine, we have children coming from all four corners of this state. We have a transportation policy so that we can work with them to help provide support if they're in financial need to do so.
Okay.
And I believe we submitted that transportation policy in our application.
You did. Are there any barriers that you're aware of, legal or otherwise, to Connecticut Children's offering to reimburse patients for any excess travel costs that they incur from going to Waterbury to Hartford?
Please repeat that.
Are there any barriers, legal or otherwise, to CCMC offering to reimburse patients for travel expenses from Waterbury to Hartford?
I will defer the legal piece to our attorneys. The other is no, we have a thorough process where people can apply to qualify for those assistance.
Okay.
But to the legal aspect, I defer to our general counsel and our external counsel.
And hearing officer Chuka, just for the record, there is some sensitivity around arrangements like that under federal statutes. So you would need to ensure that there's a safe harbor provision that protects you from anti-kickback statutes, things like that. So that the answer to your question is potentially there are barriers to being able to do that on the legal side, but it's something that we would have to explore on a case-by-case basis.
Okay. So I want to back up a little bit and talk sort of about how the process worked when the unit was open at St. Mary's and what happened with sort of the triaging of patients. So when it was still operational, a pediatric patient would present to the hospital and a decision would be made to either admit them, discharge them, hold them for observation, or transfer the more acutely ill patients to Hartford. Is that sort of generally correct, my explanation of that?
So that sounds accurate.
So since that triaging, and I'm using triaging, I don't know if that's the correct word for it. But since that triaging decision is now being made in Hartford rather than in Waterbury, are there now more patients having to travel to Hartford than were previously to reach that step of, figuring out what level of care or observation a specific patient may need?
I think I would frame it differently and actually say that the triaging still occurs at St. Mary's ED, meaning, they have a specific pediatric focused ED with the leader of it is fellowship trained, meaning specifically trained in pediatric emergency medicine. And the triage decisions occur in the St. Mary's ED, meaning, just as you said, the child would go home or be acutely transferred by a transport team with high advanced life support capabilities, etc. That would be the more severe child. And then the more common sort of middle of the road child would be transferred by regular EMS services to Hartford if admission was needed, or they might just go ED to ED, to get evaluated in the Connecticut Children's ED. So the difference obviously is that there would no longer be the option of admitting them for OBS or inpatient within St. Mary's Hospital. So I think I turned the focus to St. Mary's ED and the process there, but I'm happy to talk more about what happens in Hartford also.
So is it fair to say then that the process is essentially the same for patients who are arriving at St. Mary's now versus when the unit was still open?
Except for the same, except for the lack of having the ability to hold the patient and, to have the patient in obs or inpatient status within the St. Mary's unit at St. Mary's. Everything else would be the same, yes.
Okay. So for the patients who are determined, a determination is made that they should be held for observation, they are transported to Hartford now for that service.
I'm sure it's family dependent, but yes, most likely, um, that would be the process, to go to Hartford for admission if they needed that. Um, does that
Okay.
make sense, Bob? I think that's the most likely scenario.
Yeah, it's if there is a need to have a child hospitalized, they will be transported uh, to Hartford. As we stated earlier in testimony, the need for those type of obs patients that we were seeing there where, they may stay for 23 hours or less, that continues to decrease as the primary care practice is doing a wonderful job of managing. And then the ED there is non-discussed what they're trained. But those that need actual hospitalization would be transferred if that's what the parents chose to do.
Okay. So all of those patients would be transferred rather than self-transport. So they would have to access EMS or some other higher level of transfer.
That's right. Yeah.
Okay.
Just from a safety perspective, we typically wouldn't put them in a car because it's too much risk. We would want to have, safe transfer of those patients, whether that's it depends on the acuity of the patient, like if an EMS versus a full advanced life support transport team. Depends on acuity, but we typically, in any ED, we wouldn't put them in a car if we felt they needed admission.
Okay.
And Hearing Officer Chuka, if it's helpful, we did provide a table with some data about the number of patients, transfers from St. Mary's who were referred to OBS. That's at page 210,
Yeah.
issue number
Uh,
4.
On that table, and I mentioned this earlier, I was wondering if we would be able to get a snapshot of what happened before February or what things looked like before February 2025, even if it's just like a year worth of data. Would that
Leading
be
up to
available?
January 2025.
Right.
Yeah.
Just so that we can get a sense of what it looked like before and after.
Bob, that should be data we're able to provide, right?
We'll work with the team to provide you that information, sir.
Okay. That would be great. So I will pick that as a late file that we can notate for later. Um, okay. I think that's all that I have on those. I'm going to ask a little bit about financial feasibility and cost to the state healthcare system as well. On Bates page 32 of the application, Connecticut Children's mentions an anticipated $300,000 annual expense reduction and a $900,000 savings in annual lease payments. I know that the primary driver for your decision was lower census than desired. But what role did these savings play in Connecticut Children's decision to relocate the unit to Hartford?
Expenses. So there were a couple of things that made us in this decision. One, you highlighted the low census that we had there, the average daily census being less than 3. So from a quality standpoint, that always becomes concern because you have to have a number of kids to keep up your practice and those things. So safety and quality was one area that we focused on. The others have been highlighted both in the application, this conversation, is the expense that we're bearing, keeping that unit open for such a low census. And with limited financial resources and trying to decide how do we best care for more children in a safe and a high quality manner, that was those expenses, those loss, were what helped really drive this decision. So going back to our earlier conversation with a large number of Medicaid population, and you mentioned the overall cost to the state of Connecticut, it's actually more prudent to provide those resources here in a high quality manner than it was to continue to absorb those costs in Waterbury.
I will refer to those as savings or you know, I don't know, expense reductions, but are those earmarked in any way to fund any of CCMC's current or future strategic initiatives or projects? I know it all goes back into the system, but we were looking specifically at whether those again had been earmarked for anything specific.
Nothing specific. As a a charitable organization, not for profit, any dollars we get go into the care of our kids. As I stated earlier, we look to see how we serve more kids safer and better, and those dollars go into that general rule of providing care to all kids for the state of Connecticut, including those in Waterbury and surrounding areas.
Yeah, I agree with that. And one of the things, I've worked in other places, and at Connecticut Children's, I never know what type of insurance people have, or in rare circumstances it comes up, but we treat all kids, as they come in through the door, and we will continue to do that always.
Did that answer your question, sir?
Yeah, it did. Thank you.
Want to make sure. Thank you.
The answer to this question will come out in the data that you've said you can provide as a late file. But in a general sense, do you have an understanding as to whether there are more patients being transferred by ambulance now versus prior to cessation of services at St. Mary's?
I would defer to Dr. Sakaran on that.
Yeah, can you just repeat that, please, hearing officer?
So in terms of patients from the St. Mary's area, do you have a sense of whether there are more patients being transferred by ambulance to the Hartford facility now than there were prior to the cessation of the St. Mary's unit?
I don't have that data, but I'm just thinking logically, if the unit is no longer available, a patient who would need to be an inpatient or, admitted for OBS care would need to transfer to elsewhere. So there could be an increase, but I think we can try to get at that data specifically. If I can comment on a more global level, as I talked about in my opening remarks, there's been a general increase, in patients who self-present, families who self-present to the Children's Hospital EDs, regionally and nationally. It's just a trend that has occurred when it's feasible. Obviously, in more rural areas, when it's several hours away, it's more problematic. But when it's within an hour, we've seen increases in the Children's Hospital ED at Connecticut Children's, with significant increases over time in the total number of kids who present to our ED at the main hospital. But in terms of exact data, we could probably, we would have to do a follow-up on that.
Yeah, and I think the late file will show that, but I was just looking for, what your general sense probably was.
I can give you a general sense, but it would not be based on data.
Okay. I'm not looking for that. So thank you, sir. Something I never thought to ask until a few minutes ago when you were talking, Mr. Duncan. Does either CCMC or St. Mary's have a helipad?
I cannot speak on behalf of St. Mary's. The helipad here is shared with Hartford Healthcare. So the helicopter will land on Hartford Healthcare's pad, and we have a tunnel and a process which kids are transported from helicopter to our ED or straight to our OR as needed.
Okay. Dr. Sakaran, do you happen to know whether St. Mary's has a helicopter pad?
I don't know. No, I don't know, because I'm only familiar with Connecticut Children's Trauma activation.
Okay.
But we can follow up and get that information to you.
Again, I'll speak with the team, but I don't think that'll be necessary. From a quality and safety perspective, when operational, was the St. Mary's unit treating any patients for conditions where it would have been unsafe to transport them to Hartford from Waterbury?
Sorry, if I can go back, I'm getting informed that there is a St. Mary's helipad, but we can do a follow-up confirmation.
Okay.
Sorry, can you go ahead with what you just said?
Sure. When the St. Mary's unit was operational, was it treating any pediatric patients for conditions where it would have been unsafe to transport them from Waterbury to Hartford?
No, we were very specific with that. From a safety perspective, what you don't want is to have a child who's borderline, who's maybe going to need a higher level of care, meaning intensive care. So we would not have that patient on the unit because it's much higher risk to transport a critically ill child, after they've worsened or in the middle of the night, that sort of thing, under duress. So typically, if they were in need of critical care or higher level of care, they would have been sent from ED, the St. Mary's ED. So typically, as we said in the documents, the St. Mary's unit took care of more routine pediatric care, mostly OBS care, actually. And the things we talked about already: asthma, bronchiolitis, pneumonia, fever in babies, jaundice in babies, no, and fairly routine things. So very high critical care, borderline critical care, we would have transported already from ED in St. Mary's. So there's really no change in that process for the sicker kids.
Okay. Um, thank you. I have a couple more questions. These are about some of the utilization data that was supplied in Exhibit M, which is Connecticut Children's response to the hearing issues. Mr. Duncan and Dr. Sakaran, do you happen to have that available to you?
Yes,
Um,
I'm slow at looking things up, but yes, can you
if
give
you
me a page
can,
number?
yes, page. So if you look at the very bottom of each page, it says CCMC and then there's a number. I'm looking at 0207.
Thank you.
And specifically the table that is about a halfway down the page under B. Just let me know once you've reviewed that.
0207
Yep,
under B.
correct.
Yeah, I've got it.
Same here.
So can either or both or just tell me specifically what is being depicted in that table? Just describe it in sort of layman's terms if possible.
Let Dr. Sakaran go to the clinical aspect, but from an administrative aspect, what it shows is your patient days, that's the number of days someone is in the hospital. And you see the decrease in the days. That speaks to the OBS conversation that Dr. Sakaran had just shared. When a child is admitted, they're not spending as many days there. If it's an OBS, it's usually a 23 to 30-hour stay. But Dr. Sakaran, if you want to get the clinical aspect of it.
Sure. Yeah. So I think what it shows is a decrease in some years in the total patient days. That's the top row that starts with 789 and goes across. 2025 is going to be expected to be lower because that's when the unit, we reallocated patients. So I would kind of ignore that. But you can see going from 2015 to 2024, there's been a gradual decline, especially 2020 and 2021. 2022 was, of course, the triple-demic surge when we had a big increase. So that reflects the total patient days at the unit. And then looking quickly at the percentages, it looks like that's the percent of the utilization of total Connecticut Children's emergency admit days. And as the number of patient days decreases, you can see that the percentage utilization of the total inpatient days decreases. To me, the more useful number is the top row of patient days, showing a gradual decline over time since 2015.
You take
Okay.
that number and divide it by 365, that's where you get that our census has been less than average daily census is less than 3 or more.
Mm-hmm. So perhaps this issue was framed incorrectly, but the thing we were trying to understand is what utilization of Hartford looked like by the St. Mary's PSA population prior to stopping that unit and what it has looked like since. So are you able to provide that sort of information for, I don't know, the most recent 5 years or so?
Hearing Officer Chuka, just so I understand, this is Ben Jensen. You're looking for a percentage of, at the Hartford campus, the utilization by individuals coming from the St. Mary's units PSA?
Correct.
We should be able to supply that information.
The one potential barrier that I might see is that you may not know what St. Mary's PSA is generally across all of their services. So if you can use, if that's not available, perhaps something like the Greater Waterbury area as the starting point, that would be helpful.
And hearing Officer Chuka, I think that we did in other parts of the application provide a calculation, or at least a list of what we considered to be the St. Mary's unit PSA. So unless there were any concerns with the way we did it in other areas of the application, I expect that we should be able to use that same kind of baseline.
Okay. Yeah, I just want to make sure that it shows, prior to and after the cessation of services, what it looked like. So if that's already in there, then great. You could just direct us to where it is in the record. If not, if you could supply it, that would be helpful. So I'll note it as a late file, but it may not actually be a late file, and we can address it at that time. All right, I think those are all of my questions. I want to take, let's say, a 10-minute break. We can come back at 11:30. I just want to make sure that all of our questions have been addressed and answered, and we can take public comment at that time, and assuming there aren't any additional questions, and then we can go over late files and wrap things up. So we will definitely be done by 12 o'clock, barring any unexpected changes. So I will see everybody back in about 10 minutes. And if to members of the public, if you would like to make public comment, please add your name to the Q&A in the Teams meeting. And again, we will turn off the recording, but your video and audio may still be accessible while we are away for the next 10 minutes. So just be aware of that. Thank you very much, and we will be back soon.
Thank you.